Angela is a 30-year-old Aboriginal woman who was admitted yesterday to the IDC for fever and dyspnea experienced over the past 2 weeks. Relevant past history includes involvement in sex work and injection drug use since the age of 20. At admission and after obtaining her consent, a rapid HIV test was performed, yielding a preliminary positive result. Angela's current health situation is very poor.
So how did this happen? Let's try and understand some of the underlying risk factors. In the early 90s, the prevalence rate of HIV among injection drug users in Vancouver was nearing 30%. As a result, a public health emergency was declared in 97, and thanks to the implementation of harm reduction principles, the situation has gradually improved. However, today, 13,000 British Columbians still live with HIV and AIDS. Although many Canadians dismiss the idea that colonization still has an impact today, residential schools inflicted trauma and violence on Indigenous families for more than 100 years, resulting in the loss of generations of familial networks, parental role modeling, and devastating Indigenous language and culture. Not uncommon for individuals who end up in the downtown east side, Angela's trajectory demonstrates the cumulative effect of risk factors that impacted her throughout the life course. The first 5 years of life are a particularly developmentally sensitive period of time, which will shape the social and health outcomes well into adulthood. For each level of educational attainment, there is a dose-dependent response for risk of morbidity and mortality. In Canada, 1 in 4 Aboriginal youth will not graduate from high school, 30% lower than the rate among their non-Aboriginal peers. Among young people, stable housing has been shown to reduce the influence of negative peer networks and support educational attainment. Among injection drug users, stable housing has been shown to reduce public and unsafe injecting practices, as well as syringe sharing. So now what?
In 2000, in response to this, syringe distribution was integrated into a number of health services across the downtown east side. It became a distribution service rather than an exchange, so people could take as many clean syringes as they needed. And the operating hours were extended and mobile services were expanded as well. What happened after these policy changes were implemented was a dramatic and significant decrease in the proportion of people reporting syringe lending and syringe borrowing, 2 markers of syringe sharing. And we know that syringe sharing is a primary risk behavior for HIV transmission among people who inject drugs.
Let's go back to Angela. What if population interventions such as the Housing First model, education initiatives to ensure high school completion, and low threshold employment opportunities were implemented? Do you think this would have broken the chain of adverse events leading